Good evening, everybody. Hope you all are doing well. Nate Lighthizer, faculty member at the Oklahoma College of Optometry in Tahlequah, Oklahoma, at Northeastern State University. Been in charge of electrodiagnostics clinic for a number of years, along with my colleague and friend, Dr. Neil Whittle. And we do the electrodiagnostics at the College of Optometry. Been doing it since 2009 and enjoying every minute of it. It's my pleasure to share the virtual stage with Dr. Mike Cymbor. Mike, it's fun to do these. I'm looking forward to doing this again, buddy.
Nate, I always enjoy it, and there's so many pearls that I learn from you every time we do this. I'm from Nittany Eye Associates in State College, Pennsylvania. I've been using ERG technology for about the last 4 or 5 years. I kind of got into it on the glaucoma side, but what's amazed me is how fun it is to work on the diabetic retinopathy side. That's not something I was really that involved in prior to ERG technology, but I find that and along with OCTA has really gotten me involved at a much deeper level, much better understanding of diabetic retinopathy. So while I'm a glaucoma guy at heart, I'm really enjoying this diabetic retinopathy space and happy to be with you and be with you tonight, Nate, as well. Happy to share our insights this evening.
Yeah, and it's fun because, Mike, we continually learn all the time. We've got new technology, we've got new devices, enhanced learning. We continually update how we practice. I guess that's why they call it the practice of optometry, and electrodiagnostics is no exception to that. We learn more, better technology, handheld technology, better reference databases, and it just allows us to use this in more and more and more conditions and give us more valuable information to make better decisions for our patient. At the end of the day, that's ultimately why we are here, is to make the best decisions that we can for our patients, for their short-term management and their long-term management. So ABCs of ERGs, I know we have both potential customers, people that are interested in ERG, don't quite have the technology yet, and we also have some users as well. So we're going to try to mix and match pearls for people that already have the device and implementation and utilization, as well as talk on the attractiveness of why you would want to bring this into your practice. So if you've been to my lectures before, we like to poll the audience. So if you grab your phone quickly, and scan that QR code. That's going to bring up a quick question here at the start. So just scan that QR code, click the little button. If it asks you to sign up for anything, if it asks you to download anything, you don't have to download anything. Just skip for now, and it will bring up this opening question where we're going to talk on structure and function. Mike, we do structure and function so very, very well in a lot of conditions. Your thoughts on structure and function and its importance and usefulness.
Yeah, so we know in the field of glaucoma how important structure and function is. And remember, there was a time when managing glaucoma where if you would have asked, hey, how do we manage function in glaucoma, we would have said visual acuity. And we now know the importance of visual field testing in managing glaucoma. Yet we're involved in an eye disease like diabetic retinopathy, where if we ask the average practitioner, what are you using to determine visual function in diabetic retinopathy, the answer is visual acuity. And so I think part of tonight is just to say, hey, for you those of you already doing ERG technology in the management of diabetic retinopathy, great. We're going to talk about that at a really deep level. But for those who are just thinking about it, we're also going to just touch upon it so that you'll understand why we are so excited about this instrument in optometric care.
And do you think testing structure and function is important in your patients? Well, look at that. 100% of you think that this is important. So we don't have to convince you that structure and function is important in our ocular pathology patients. I've asked this question many, many times, and the answer is usually 100%. Yeah, we need to look at structure and we need to look at function as well. Structure and function in ocular disease. Tonight, we're going to focus on diabetes and diabetic retinopathy. It is the number one condition. It is the number one protocol that we are using the RETeval ERG in our clinic. We use it for other things like glaucoma, other retinopathies, unexplained decreased vision, color vision abnormalities, other visual phenomenon. But with all of those other things, still the number one is diabetes and diabetic retinopathy. And as Mike said, what are the most common ancillary tests that you guys use in diabetes and diabetic retinopathy that we use in diabetes and diabetic retinopathy? And the answer is always, well, it's fundus photos, it's OCT. Those are the two most common ancillary tests that go along with our dilated fundus exam. We do a DFE. And when you think DFE, when you think fundus photos, and when you think OCT, that is structure, structure, structure. You are looking at the structure of the back of the eye right now with these fundus photos. You are looking at the structure of the retina with these OCTs, and we're all so used to looking at OCTs. Normal OCT here, OCT with macular edema in this particular patient here. So we're looking at structure. We're looking at structure. We're looking at structure. Again, as Mike said, why is the only functional test that we do in diabetes and diabetic retinopathy visual acuity? And by the way, visual acuity is not a great indicator of how your diabetic patient is functioning. They may be 20/20, and yet they are progressing through the stages of diabetic retinopathy. I want to challenge you. I know Mike wants to challenge you guys this evening. Is there more that you can do than just doing our structural tests? Let's mix and match structure and function. And again, you may think, electrophysiology, this is something that when I think of electrophysiology, that was something at school, Mike. I mean, that there was this room in the back and there was no windows in there and there was wires everywhere. And you didn't want to go back there because who knew what was going to happen in this lab with wires everywhere, Mike? I mean, this was you in optometry school, wasn't it? I mean,
absolutely. It was, we would wait for Gandalf to come into the room and shake his wand, his staff, and try to figure out what all this stuff meant. So it was more smoke and mirrors, it seemed like at the time.
This is not, this is your grandfather's electrophysiology. This is your father's electrophysiology. When we look at devices that look like this, which I'll come back to this slide, the RETeval, this is now what electrophysiology is over the course of the last 10 years, and it's evolving and advancing and getting better and better and better. And again, this ain't your father's electrophysiology. And just like OCT, if I go back a few slides, you take a look at the OCT. Mike, OCT started with this, and this was revolutionary in 2005, even up to 2010. Time domain, the Stratus OCT. This is what I used exclusively in my schooling from 2005 to 2009, and it was awesome. But we look back at this now and go, well, that would be like archaic as the technology advances and we get better and better. And electrophysiology, it's really doing that right now to go from, this is the first system. And I put this slide in. This is the first system that we started with in 2009. When I was a resident in 2009 and 2010, my first experience with electrophysiology, LKC was there. This is their EPIC system. And it looks like a visual field. And you had to put your chin in there and, in this little bowl, and it flashed lights at you. And you had to use electrodes that were called ERG jet electrodes that looked like RGPs right on the cornea. And it's completely evolved. It's completely different. Mike, technology does this, doesn't it?
It does. In fact, I'm just laughing because on the left, that almost looks like my stereo system from the 1980s,
It certainly does. It evolves and it advances. And this is now what Mike and I have in our clinic is the RETeval. And this is a handheld ERG that we take right to the patient. Dilation not required. Actually, some of these protocols, dilation, you can have them dilated, cannot have them dilated. Other ones, you can have them dilated. So it's not required. And it has been so fun to be able to see the patient reaction as you bring an ERG right to them. Patients love this. They are incredibly impressed that their doctor has the latest and greatest in technology. I phrase this to patients of, have you ever had an EKG before? This is an EKG of the back of the eye. It's amazing how all patients know what EKGs are. Yeah, I've had an EKG, doc. I know what that is. And you say, this is an EKG for the back of the eye. This little device here, I'm going to put it up to your eye. Nothing's going to touch the eye. It's going to flash some lights in your eyes, and it tells me how's your retina firing? How's your retina functioning? How is your retina working, basically? And we're going to pair this with fancy pictures to give us a complete retinal picture. Mike, patients just love that, don't they?
They absolutely do. And how many times through my other visual function tests, how many times do we hear complaints from patients? Oh, do I have to take a visual field? I do not want to take a visual field. I hear it even more with dark adaptation. That's going to take me, last time I did it, it took me 20 minutes to get through that. I don't want to do that again. I have never had a patient complain about having an ERG done because it's portable, it's quick, it's efficient, and patients are done in a matter of minutes. And so it's just a good technology that we can incorporate in our practice.
When we got this in our clinic a couple of years ago, it was just amazing to realize how powerful this device is. I mean, Neil and I, our chief of electrophysiology, and myself, will dive into the electrodiagnostic weeds. We'll get into ICEV protocols. ICEV is the International Standard of Clinical Electrophysiology and Vision. I mean, that's diving into the weeds. And my point is you can do all kinds of scotopic and photopic and step 1, 2, 3, 4, 5 and all this stuff. And you can do that if you want in rod cone dystrophies, cone dystrophies, retinitis pigmentosa. You can do that if you want. This device has all of those protocols if you want. Now, how often do you see patients with cone dystrophies or rod cone dystrophies? Not very often, but you can use many, many, many other protocols like the diabetic retinopathy protocol, the photopic negative response, the Flickr 16, these protocols that are your bread and butter, your day in and day out. That my point is you can have the common protocols like the diabetes, or if you wanted to, dive a little deeper, you can do that. It's all wrapped into this handheld device, which is awesome. It provides you just so much clinically valuable information. CPT code 92273 for the ERG. You can see the average reimbursement on the bottom. It's about $126 nationwide for that code. Because this is structure and function, you can do function. You can bill that code, the ERG's function. You can bill your structural test with this. You can bill your fundus photos. You can bill your OCT because that's structure and this is looking at function. So you can do both of them. And Mike, you would know this much better than I. I'm in academia. You're in private practice. Does this technology, for a win-win for patients and practices, you got to have return on your investment. You got to be able to help patients, but you got to have a technology that does something or other technology doesn't. Mike, this does that. We've got function and we've got it objectively, correct?
Absolutely. It's objective function. It gives us information that we can't get elsewhere. And from a billing coding standpoint, it's one of the highest reimbursements that we have out there. And one little known fact is that, a lot of times if you're submitting to Medicare or, a private insurance, and you do many procedures same day, you're taking a hit on the second, third, fourth procedure. One little known fact is that with ERG technology, they do not reduce those reimbursements. They kind of keep those separate. So whether, if you're doing a visual field OCT and an ERG, it's going to leave the ERG alone. And so from a billing coding reimbursement standpoint, it's really very difficult to beat.
Does it provide clinical information that will impact the treatment of our patients? The answer is yes. There's a study by Brigel, among many other studies, that have looked at how do you enhance risk assessment. Isn't that our job often in retina, diabetes, diabetic retinopathy, and other retinal conditions is how likely is this patient going to stay stable? And how likely is this patient going to go south? If you knew your patient was going to go south in the next year, I bet you'd be more aggressive, maybe an earlier referral, earlier to initiate treatment. You would follow that patient more closely or maybe trigger referral versus if you knew a patient was going to stay stable for the next 3, 4, 5+ years, you're going to follow that patient more differently. Education would be different. So we use structure and function. And the Brigel study, among others, has shown us that when we have abnormal structure and abnormal function, those patients are more likely to progress, more likely to need intervention, and we should follow them more closely, maybe do additional education, additional testing, start a nutritional supplements. It gives us a lot of information. Again, it's objective and it's function. Can it be incorporated into our office? That's the beauty of this, is this takes no space because it's handheld right to the patient. And I've been so surprised on how patients, I didn't expect this, how much they love this and think this is cutting edge, leading edge, how it is cool that their doctor has this amount of information to give them the best care possible. So I would say this is leading edge, this is cutting edge, and it's starting to become standard of care and more commonly utilized in practice. And it's very, very patient friendly, profitable practice building, as we've talked about. Mike, anything to add to this slide?
Yeah, why is it leading edge? Why is it, going to become standard of care? We talked about reimbursements, and that's great. We talked about portability. All of those things are very important. But the main reason to utilize this technology is because it's going to change the way you manage diabetic retinopathy. And I know you agree with this, Nate. There's so many times that based on our current guidelines, is there are times where I see a patient with mild non-proliferative and I see a DR score that's 22, and I think, wow, they're only mild non-proliferative or a moderate non-proliferative. Maybe they just got to be moderate, they just met the criteria, and you think, well, this patient has several years before I need to worry about them. They're only moderate, they're not severe, but yet we do a DR score at that moment, and they're really close to that 23.5 cutoff. So it is going to revolutionize the way that you're going to manage diabetic retinopathy. And for those that are on tonight, you may already be using it regularly. And we can't wait to hear some interaction from is it changing the way that you manage these patients? It certainly is in my case, and I know, Nate, it is in yours as well.
Yep. So, what is this test? This tests the full retina. It's a flash ERG. It tests the superior, inferior, nasal, temporal, central, peripheral retina. This is an overall test of retinal function. That's what it does. Visual acuity is very, very localized. It's dependent on that central 2 to 3 degrees. So if they've got the central 2 to 3 degrees that are okay, they may have a good visual acuity, and the rest of the retina is kind of junk. It's not doing well. So we need to do other testing. OCT does a fabulous job looking at the structure of this. 24-2, visual field and pattern ERG is more central function, as you can see here. The flash ERG, the full field ERG, is the entire thing. Overall, globally, how's the retina doing? Top to bottom, left to right, superior, inferior, nasal, temporal, central, peripheral. Globally, how is this retina doing? And when do we want to know globally how's the retina doing? Diabetes and diabetic retinopathy. Lots of functional lots of functional things that this can assess, many conditions. Again, we've talked about medical retina, your diabetes, diabetic retinopathy, vein occlusions, artery occlusions, hypertensive retinopathy, your optic nerve conditions, your pediatric inherited, much more rare, but we've got to have it if needed. Anytime you think to yourself, I'm trying to figure out what's going on. They've got unexplained vision loss. They've got color vision defects, either objectively or subjectively. They've got peripheral visual field defects. They've got nighttime vision complaints. When you're trying to figure out what's going on, have you ever got a visual field to try to figure out what's going on? An OCT to try to figure out what's going on? Get an ERG to figure out what's going on. How's the retina functioning? We've got a lot of different conditions where we can functionally assess what is going on with that retina, that optic nerve, a diverse array of conditions there. Mike, anything to add on that slide?
Yeah, I'm so glad that you raised the hypertensive retinopathy point, because I know some of us are saying, wow, maybe I just don't see that many diabetic patients in my practice. Okay, that may or may not be true, but now if you add hypertensive retinopathy, there's so many patients. It is an epidemic of hypertension in the United States, and so once we throw hypertensive retinopathy into that mix, your ability to run ERGs on a large number of patients really expands exponentially. And so do it for the diabetic retinopathy, but don't forget about hypertensive retinopathy either.
Yep. So again, diabetes is going to be the number one, but hypertensive is going to be up there as well. Your retinal dystrophies, your glaucoma, we won't talk much about it tonight, but the photopic negative response, which tells you about ganglion cell function, ganglion cell function, that's your PHNR. That's the number 2 protocol that I do after the diabetic retinopathy protocol, the DR assessment, the DR score. That's my most common protocol. The photopic negative response is the second most common protocol. And then our Flickr 16 is our third most common protocol for hypertensive retinopathy, other retinal disorders, other retinal dystrophies. But again, don't forget about those patient symptoms where you're going, I'm trying to figure out what's going on, unexplained decreased vision or things like that. So how do you interpret these? When you look at ERGs, don't get overwhelmed with ERGs. And again, you remember school and you're thinking, oh, I'm never going to use these ERGs because that's in the research center, that's at school, an academic center, it's for studies. It's not for clinical practice. That is no longer true, that this is not for clinical practice. And how do you interpret ERGs? Well, I think of ERGs. I want my ERGs. Mike wants his ERGs like he wants his Penn State football players. He wants them strong and quick. You want your ERG, right? Isn't that Mike? You want your ERG
so
strong
true.
And quick.
Yes.
And it's just like EKGs. And none of us are cardiologists, but we can also all recognize that that's a general, normal EKG. And what do I mean by strong and quick? The strength is the height of the peaks. How high are these peaks, or how low are those peaks on the bad end? The height of those peaks, that's the strength of the response. And the speed is how quickly those peaks are happening. If you go to the ERG here, looking at the bottom, this is that Flickr 16 protocol, a protocol that I would use in hypertensive retinopathy or other retinopathies other than diabetes to look at how is the retina functioning. Let's look at the bottom, right eye and left eye. Okay, so right eye over here and left eye. I'm looking at the strength and I'm looking at the speed. And the strength is the height of these peaks. And the higher the peaks, the better. That's the stronger the retinal response, the strength of the retinal response. I think of the strength, it's called the amplitude. I think of that as the weightlifting competition. If you were in a weightlifting competition, do you want a small number or do you want a big number? The answer is you want a big number in a weightlifting competition. So when I look at the actual number right here, I look at this percentage and I go, okay, from 0% to 100%, the higher the percentage, the better. Weightlifting, big number, and I want the higher the percentage, the better, okay? And also the speed. These peaks here, I want them to occur not slow, but quick. I want them to happen. I want the retina to be responding like it should be. And you can see it gives you a little kind of cheat sheet. This little rectangular box is guidance of where that first peak should fall. And you can see here that we have a line. This little vertical line is showing right where that first peak falls. It's right in that rectangular box. And it's saying this retina is responding in a quick fashion, just like it should. This is a 100-yard dash. Your implicit time is a 100-yard dash. If you're doing a 100-yard dash, do you want a small number or a big number? You want a small number. So unlike the amplitude where we want a big percentage, for the implicit time, we want a small percentage. The smaller the percentage, the better for the implicit time, and the bigger the percentage, the better for the amplitude. We want strong and we want quick. We want strong and quick. Anything to add, Mike?
Yeah, there was a question in the chat that said, for hypertensive retinopathy, is it most appropriate to use the Flickr 16, or can you use the DR score? So I'll throw my hat in the ring, and Nate, I'm curious to hear what you say. So I think the Flickr 16 is an excellent protocol for hypertensive retinopathy. I also think hypertensive retinopathy gives ischemia in maybe a similar way to diabetic retinopathy. What I don't know is how that affects pupillary response. And I suspect that hypertensive retinopathy affects pupillary response in a slightly different way than diabetic retinopathy does. And so it might throw off the DR score. So if you use the DR score in hypertensive retinopathy as a way of monitoring hypertensive retinopathy progress over time, maybe that would be an way to do it. But I would also say that I would be a little cautious, because the 23.5 number that's so important in diabetic retinopathy, I think you have to kind of throw that out.
I agree with everything you said, Mike. I don't do that. If for hypertensive retinopathy, I use the Flickr 16. I just don't know the pupil response in hypertensive retinopathy and how it affects that. And the DR score was very well validated for diabetes and diabetic retinopathy, and I don't know it in hypertensive retinopathy. So I don't do that, haven't done that before, and I stick with the Flickr 16 for our hypertensive retinopathy.
Good.
Speaking of our number one and I always make this point of going, here's normal. You guys all know that that's a normal EKG and a normal now ERG at the bottom. Well, you also know that's an abnormal EKG there. And look, the peaks are reduced, and obviously there's no time. That's a flatlined EKG. And here's an abnormal ERG. And look how this is both low and slow. Those peaks that should be landing in these boxes here, they are lower than them and they are slower than them. They're occurring after they should be in those rectangular boxes. This is low and slow. And remember, the time, the milliseconds, is supposed to be a small percentage, and this is as big as it gets, so that's bad. And the strength is supposed to be a high percentage, and that's as low as it gets. I mean, this is very low, very slow. This retina is struggling. This retina is likely ischemic, and this is bad news for this particular patient there when we're looking, again, at these waveforms, okay? Anything to add, Mike?
No,
Okay.
That's great.
All right, on to the number one protocol that we do, which is the DR protocol, the DR score. And again, we've already covered much of this. So we've covered the nuts and bolts and reading these kind of waveforms here, right eye and left eye. When I do a DR score, our DR assessment protocol, the first thing I look at is the DR score. This has been validated and has been shown that we want this number to be 23.4 or lower. The lower the number, the better. This is like Mike's golf game when he shoots 65 on the weekend, in Pennsylvania somewhere. He's a great golfer. The lower the number, the better. Okay. If 21, 20, 19, 18, if I see a score in the teens, awesome. But I start and I finish this interpretation of looking at the DR score. This looks awesome. Okay. Then I dive down here and I look at, again, our waveforms. Are they low and slow, or are they where they should be? This is a very, very normal example, and you can see that our peaks are where they should be. They have an appropriate strength, an appropriate time. This is a reasonably normal, a good middle-of-the-road normal response. Notice our time. Again, we're all in the green. Again, kind of close to the middle of the range. Our strength, our speed is close to the middle of the range. Our strength is kind of close to the middle of the range. Note there, if you had to choose, though, which eye's responses are a little bit stronger, the right eye or the left eye? Which waveform looks a little bit stronger, the right eye or the left eye? Hopefully you're answering the right eye. Those peaks look a little bit higher in the right eye compared to the left eye. Notice I validated that with the numbers here. We're right in the 50th percentile right eye, and still in the normal ranges, but only in about the 12th to 14th percentile in the left eye. So very, very normal response. Overall, just kind of comes some nuances that I would notice as I'm interpreting this. Mike?
Yeah, and the interesting thing is, if you look at the pupil response, a lot of times pupil response asymmetry, gives you a lot of clues. But in this particular case, the pupil response is almost identical in each eye. And so despite the fact that you're having an ERG amplitude reduction in the left eye, surprisingly, the pupillary response is very similar. So the ERG, this particular unit, really gives you so much additional information. And sometimes it's it's not exactly what, what you would expect. And that's really kind of the beauty of the instrument.
So you can't know what abnormal is until you know what normal is. So this is normal. Again, very, very good. Looks normal. Here is abnormal. And you take a look at this patient and immediately go, all right, the DR score. Remember the cutoff, 23.4. 23.4 is the line in the sand. Less than that, normal. Above that, abnormal. It means the retina is not responding like it should. All right, I've got an abnormal DR score. We're outside the limit range. And then we go down to our waveforms. And you look at these waveforms, and I'll ask you, are they more low or are they more slow? Are they more low or are they more slow? And again, hopefully you answer in this case, they're more slow. These peaks, they're not bad in terms of the amplitudes. They're in about the 35th percentile, give or take, for the strength. You can see that's in the normal range, right eye, and normal range left eye. But notice the peaks are falling behind these rectangular boxes. This retina is just not firing like it should. It's not being efficient handling that flash of light, and therefore this retina is just not functioning like it should. So we are more slow in this particular case. So abnormal and normal there back on the previous one. Anything to add there, Mike, before we get into the cases?
Yeah, and in that case, you saw how different the pupillary response was, whereas the pupillary response in the right eye was much worse than the pupillary response in the left eye. That's so important when it comes to the DR score, and that's one of the things that I like to look at.
Yep. All right. So again, we've talked about the vital role in disease management. How does this change? If I see this, again, I'm going to follow this patient more closely. I'm going to educate this patient in a little bit different manner. I'm going to consider nutritional supplementation. I may consider color vision testing or OCT angiography. Again, maybe communicate with their doctor a little bit more, a little bit better. There's a lot of things that we're going to change. Follow-up schedule, see them back, educate them more, educate them better, nutritional supplementation to get this patient on the right path. Because at the end of the day, what does this mean? This DR score, this ERG of 24.8 overall means they are more likely to progress through the stages of diabetic retinopathy. Don't we do this all the time in glaucoma? Who is stable? Who is more likely to progress? You're going to treat them differently. We are now going to do the same thing in diabetic retinopathy. Who is more likely to stay stable? Not this patient. Who is more likely to progress in the upcoming year, 2 years, 3 years plus? It's this patient with an elevated DR score. All right, Mike, case-wise, take it home.
Thank you. So this case, in fact, Nate, if you can go to the next one. So 63-year-old, last A1C was 8.1. So right out of the chute, that gives us some clues. On insulin, recently started taking Ozempic and Jardiance. To make it a little more complicated, the patient in the past has had moderate non-proliferative diabetic retinopathy. So we know that the patient just didn't have hemorrhages, but also had exudates, cotton wool spots, or venous beading to meet that moderate non-proliferative diabetic retinopathy classification. Patient also had hypertensive retinopathy and, to make it even more complicated, chronic angle closure glaucoma with YAG-PI and SLT in the past. Pressure today, 21 and 23. And then when we look at the retina, and this is kind of the right eye, and I think the picture is good, but it doesn't quite do its justice. There are, if you look through the hemorrhages, there are hemorrhages everywhere. There's also quite a bit of hypertensive retinopathy we can see in the AV crossing changes. Next slide. Thank you, Nate. And in the left eye, I think maybe it comes out a little bit more, but if we looked at how much hemorrhaging is occurring, and if we broke it down by quadrants, I can count, roughly 25 to 30 hemorrhages in each quadrant. There's also a cotton wool spot there. And so because I can count, 20 hemorrhages in each quadrant, that patient now meets the severe non-proliferative diabetic retinopathy classification. At that type of classification, what do we, what do we do at that point? Well, our own AOA guidelines say at that stage, there's a 50% chance of developing, proliferative within 1 year, 50% chance. So we need to be sending this patient on to a retinal specialist. So because the patient meets the severe criteria, I'm thinking to myself, okay, if I'm going to follow AOA guidelines, I need to send this patient out at this particular stage. Next slide. We won't dwell on this. This is just kind of our OCT, and that shows us that at least over the last 6 months, the optic nerve is stable. So I'm thinking from a glaucoma standpoint, we're stable. No, that's great. And next slide. And then when I look at the macular OCT, I can see some non-perfusion. We're not going to spend too much time on OCTA, but I can see some non-perfusion in both the superficial and deep layers, but not as much as I would expect based on the fact that they met severe non-proliferative diabetic retinopathy classification. Next slide. And then over the last 6 months, that non-perfusion, actually seems to be, rather stable. Okay, now here is where the benefit comes in of functional testing, right? So I said before, the patient meets the moderate non-proliferative, the severe non-proliferative classification system. It was moderate last year, but now it's severe. So I have to be sending this patient out. But now I do the DR score, and the DR score, while some parts of this ERG doesn't look great. In fact, Nate talked about low and slow. Look how low the amplitude is in the right eye compared to the left eye, and look at how reduced the pupillary responses are. And so now we have a DR score of 22. And I will say, I want to caution you about using the DR score in a case like this, because this patient also has a couple of things that in the Burgell study they didn't have. So we have to be very careful about that. But I would contend that the glaucoma and the hypertensive retinopathy, if anything, is going to make the DR score worse and not make it better. So the fact that I have a DR score of 22, which is lower than the 23.5, that now takes me from, if I'm trying to determine risk of proliferative within the next year, it goes from 50% down to 3%. Roughly. And so, many of us would be uncomfortable sitting on a severe non-proliferative diabetic retinopathy patient, including me. But now that I have the functional testing that gives me a much better sense, and it lowers that risk from 50% down to 3%, then I'm going to be comfortable managing this patient a little while longer before sending them to a retinal specialist.
It really gives you a much more complete picture, Mike. I mean, this is a beautiful case on showing the value of this. And Mike, I'm sure there have been cases where you have one similar to this, the retinal findings, and you do the ERG and the DR score is 25.6. And that is, again, further validation that we better send this patient sooner rather than later. It's just extra validation. In this case, it kind of tipped us the other way. So does always this change us the other way? No. Sometimes it validates us and confirms that what we suspected, yep, I feel that even more strongly now after getting the ERG. This one, it tipped us in the other direction.
And so we as optometrists, we always want to send the patient at the right time. If we send them too early, then the patient's mad at us because now they're sitting in a retinal specialist's office for 4 hours, time and time again. So, and then they'll say, well, the retinal specialist didn't do anything anyway. So we don't want to send them too early, but we don't want to send them too late either, because then the retinal specialist, will say, hey, I wish Dr. Cymbor sent you over a little earlier. I'm going to try to fix this. But we want to we want the best possible outcomes that we can get, and incorporating functional testing within our diabetic retinopathy space can make such a big difference about giving us the confidence of knowing exactly, the right time to send these patients.
Any last words of wisdom on that case, Mike?
No, that's it, Nate. Thank you.
All right. Moving on to our last case here in our last 10 minutes or so. 77-year-old male, type 2 diabetic, 19 years, controlled with oral medications, last A1C 8.2. So, A1C is a little bit higher than we'd like it, but, for our patient population, it's fairly standard to see an A1C in the high 7s or in the 8s. And, you can talk to a 77-year-old male about diet and exercise, but good luck on changing a 77-year-old male's diet at that point in time. So, his A1C is kind of what his A1C is in this particular case. And he actually told us that exact thing. Yep, my A1C, I don't really care. That's where it's going to be. Visual acuity, 20/20 minus, 20/30 plus. He had a little complaints on the left side. I'm not seeing as well in my left eye compared to my right eye. Maybe it's slowly gotten worse over the last year or so. Maybe. There's the back of his eyes here. And you take a look at the back of the eyes. And not a ton of changes in terms of diabetic retinopathy. You can see we had just a small little microaneurysm change here in the right eye. So unlike Mike's patient, that was moderate, getting into severe non-proliferative retinopathy, we certainly have a much milder picture in this 77-year-old male, despite being, an A1C of 8.2, but, it doesn't look terrible at this point, just, very mild NPDR. OCT in the right eye looks pretty good. OCT in the left eye looks pretty good overall. Visual acuity, as I said, is probably 20/20 based on these OCTs. Remember, he's 20/20 minus in the right eye, 20/30 plus in the left eye. Here's the ERG in this particular case. And while, you take a look at this, and on first glance, again, it's not terrible. It's kind of in the normal range for the DR score. But again, let's dive a little bit deeper on these. We've got that DR score, but we do want to dive a little bit deeper and look at some of these numbers here. It's definitely on the slow end in both eyes. You'll notice these peaks are at the back side of these rectangles, and you kind of just, it's not quite where it should be. You look at the percentages there. Remember, from a 0 to 100%, we want a low number for the time, and we're getting pretty high over here and even worse in the left eye. How's the strength? Again, it's not terrible. Better in the left eye compared to the right eye, but still on the low end of normal here. Now, I looked at this and I went, all right, he's got some reduced visual acuity in the left eye, and he's, a little bit unhappy with his left, eye vision, and his A1C is elevated, and he's got abnormal structure, even though it's mild, and we've got abnormal function as well. And, it's borderline. It's borderline there, but I wanted to do more in this particular case, and I thought we could make this a little bit better in this 77-year-old male. I talked to him about diet, and I talked to him about exercise and all that good stuff, and it's probably not going to change that. But I want you guys to remember the effects of electrophysiology in the early diagnosis, in the earlier follow-up of diabetic retinopathy. I want you guys to remember the DIVFUS study, the Diabetes Visual Function Supplement Study. This is done by Paul Chaus and the late Stu Richer and Jeff Gerson. And it looked at patients that have diabetes and diabetic retinopathy, and it looked at this supplement. Okay, this supplement is by the I Promise DVS. Okay, this is the DVS supplement, and this was developed for retina. This was developed for vasculature. It was developed for diabetes and diabetic retinopathy, and it has a nutrient panel here, an ingredient panel that has been designed specifically to be healthy for all of that stuff. And if this is an interest to you, send me an email and I will pass you along the DIVFUS study. And Paul Chaus is one of the most knowledgeable, if not the most knowledgeable individual I've ever listened to on diabetes and diabetic retinopathy. And he developed a 12-page document, and it dives into the weeds on why all of these vitamins and minerals and nutrients are healthy for the retina and healthy for vasculature. It is a paragraph or two on each one of these vitamins and minerals and nutrients on why it's healthy for the back of the eye. And it's a deep dive. But if you send me an email, I will send you this study and I will send you Paul's document on why this is healthy. So this is now what I recommend in patients that have diabetes and diabetic retinopathy with any degree of structural issues, any degree of functional issues. Their vision is down, they're uncontrolled. Well, this patient met a lot of those. His vision was down a little bit. His A1C was up a little bit. His structure was not terrible, but not normal. His ERG was not terrible, but not totally normal. It was kind of borderline. And I decided to make a recommendation that let's go on nutritional supplementation. And what this showed, the DivFus study, is that over 6 months, a lot of functional testing improved, whether it was color vision, contrast sensitivity, many other scores as well. So I put this patient on this DBS. This was his ERG when we diagnosed. And again, take a look at this. And again, first glance, not terrible. Okay. But again, I said this was borderline. I think we can get this a little bit better. And after 1 year of supplementation, and his A1C never changed and his diet didn't change, his ERG improved to that. And you take a look at this and you notice, look at how just the smoothness of those waveforms, the strength of those waveforms, the quickness of those waveforms, we have moved this in the right direction. And if your cardiologist improved your EKG, you would be tickled pink. And if we can improve their ERGs, that means we are helping these patients. By the way, his vision improved as well, and he was very happy. Now, it took a commitment. He gets all the credit here of taking the nutritional supplement and try and maybe diet a little bit, although I doubt he was very successful on that. But we are moving in the right direction, and we can see functional improvement in these patients. Mike, your comments on this case?
Well, it's just a wonderful case. Everything you said about Paul, I completely agree with, and I love the idea of supplementation in these diabetics. The thing I would also add is exercise, the importance of exercise, and that can be, a tough road to hoe sometimes. But there will be some patients when you marry the idea of vision and exercise together. Sometimes we can do a better job at convincing them to make lifestyle changes than their primary or even their endocrinologist. So I also have seen with this supplement, and also, and this is my #1 supplement in diabetics. My #2 would be the new retin from PRN and the good fish oils. But both of those are great. And I think the beauty of measuring visual function in diabetic retinopathy, it gives us a little more confidence to make these supplement changes and see if they can work. And I've seen not only improvements in the ERG, I've seen improvements in OCTA, you probably have as well, and also improvements in diabetic macular edema with some of these supplements. So I think that this is, and these are so well studied. I think it's time for them to get their due, and having a functional test where you can monitor over time is just really a game changer in allowing us to manage these patients.
Mike, change is hard. Change is hard for all of us. And we've been doing something for a certain way for a long time. And it's been, you dilate your patient, you take a picture, you look at the back, and you watch and you wait. You watch and you wait, and you watch and you wait. We're watching and we're waiting for bleeding. We're waiting for edema. We're waiting for swelling. We're waiting for ischemia and neovascularization. We need to move on from that and just go, you know what? We need to be more proactive with these patients and have testing that looks like this, that we can improve, an OCT angiography, and recommend nutritional supplementation like this, to not just say, I'm just going to watch and wait and hope that this patient doesn't go down the road of diabetic retinopathy. I'm guilty of that, Mike, in the past, just watching and waiting. And we have now learned to be more proactive.
Yes, and that's why that case is such a great case. Watching improvement, and we being optometrists on the front lines, we can be doing this over and over, and really changing the decline. Let's quit watching the decline. Let's react and be proactive about it, and allow these patients to have better outcomes.
Yep, structure and function. One doesn't replace the other. they supplement each other very, very well. They work off of each other very, very well to give us the best picture. Mike, what questions do we have?
It looks, let's see, what's the lowest DR score ever noted? Ever noted?
The lowest, the lowest
Lowest.
one that I've ever seen is in the 13s. Have you ever seen a one lower than 13?
I don't think I've seen one lower than 13. I think that's about my lowest as well.
Yep. Yeah. The lowest one I've ever seen is like 13. I can't remember if it's 13.4 or 13.6, but it was 13 point something. That's phenomenal. That's hitting a grand slam with the ERG. That's hitting a 400-yard drive right down the middle of the fairway. The highest I've ever seen is 32.8 or something. It was in the high 32s. What's the highest you've seen, Mike?
I've never saw one in the 30s. So
Yeah.
so probably like a 28 would be my highest.
Yeah, I've had multiple of them at 32
Yeah.
in the 32s. I don't think I've had any in the 33s yet, but they were sick retinas.
Yes. Yes. Yeah. Well, let's see. There was a couple comments about PHNRs, and while we didn't really discuss that here, we can much. I think we can certainly talk about it. Is the looking at optic nerve disease? PHNR can be a really important thing, particularly differentiating. Okay, what is the functional change? Is it due more to retina? Is it due to optic nerve? I think that's really where the PHNR shines.
Yep, I agree. Photopic negative response, ganglion cell function. It's another piece of our diagnostic puzzle, whether there's diagnosis of glaucoma, whether there's progression of glaucoma in those patients. So it is the second most common protocol that we utilize on the RETeval.
Tracy Schreck actually put on here that she had a 9. She had a DR score as low as 9.
Wow.
Wow, right. I would go back and question that diagnosis of diabetes. That's pretty good.
Wow, I've never seen single digits before. Wow, yeah. That's impressive.
Yeah. One thing I'll add about billing and coding, not that there's a question, but I'll just kind of throw it out there. When it comes to diabetic retinopathy, it just has to meet mild non-proliferative. So we can't just do, diabetes, by history, type 2 diabetes, the E11.9. That is not a billable code for ERG. It has to be at least mild non-proliferative, moderate, severe, any of those classifications are billable codes with diabetic retinopathy.
Is there any use of this technology for concussions or any kind of traumatic brain injuries?
I haven't used this for concussions and traumatic brain injuries yet. Mike maybe has. I have not. When I think of traumatic brain injuries, stroke, I think more of the visual evoked potential, the VEP, since that's looking at the entire visual pathway all the way back to the occipital cortex. ERG, I think that's to be determined of how we would utilize the ERG in concussions or traumatic brain injury at this point. That's my understanding and knowledge.
Yeah, I agree with you, Nate. I've not used it for TBIs or concussion management.
Because you were mentioning pupillary response, so I thought maybe there was some correlation.
Yeah, I mean, I can envision a time where, look, I think the LKC people, and through the Burgell study, looked at pupillary response and amplitudes and implicit times, and kind of put along with age, and put all those things together and gave us a really clinically useful number. And I think they could be eventually do that in glaucoma, in hypertensive retinopathy, maybe in concussion management. So I think that we're just scratching the surface of this. We've got really good data in diabetic retinopathy, and I'm hopeful that at some point we'll be able to use it for all those other diseases, because I think we're just scratching the surface with this technology right now.
Yep.
Thank you for that question. What protocol would you use for RP or Stargardts? RP or Stargardts?
Yeah, good question. RP and Stargardts. RP, I would use a 4-test flicker. So I would look at the 4 or 5 steps, depending on if you wanted to do I'm drawing a blank on step number 3 there. But there you do the scotopic, dim flash, a scotopic, bright flash, and then you go into the photopic. So I would use the ICEV 4-step or 5-step protocol. I'd have to have the device in my hands to look at. There's multiple different protocols, but it'd be the 4-step or 5-step where it breaks it down, just the rods in dim light, the rods and the cones in dim light, and then the cones in bright light and the cones in flicker. So in those cases, if you wanted to truly dive into rods separately and cones separately, that's when you're getting into dark adapting, where you've got to have the patient that sits in the dark patched so there's no light to turn the cones off so you can specifically measure the rods. So that's where I would be getting into those types of protocols. Again, we're diving more into the weeds, but into the ICEV 4-step, 5-step. There's even a 6-step protocol where we do 6 different tests to determine exactly scotopic and photopic response, rods and cones.
Yeah, I did a flicker 16 on some of these patients, and it was basically a flat line. So I really wasn't useful for me.
Yeah, and what you want to do in those cases is it's useful. Oftentimes the rods are shot, and because they often go first, and that's flatlined. And I want to know, well, how are the cones doing by themselves? So it's just a nice way to tease them out and see exactly what's the prognosis, how much are each of the rods and cones affected by themselves. So again, it's really teasing that out, and it's next level electrodiagnostics. That's like electrodiagnostics, 2.1 or 201 or 301 or 401, but it is all there in that RETeval device.
Two final thoughts is Tracy Schreck said that her type 1 diabetic son had a DR score of 23.5 and with a hemoglobin A1C at 7.4. He got that, he worked really hard to get that A1C down, and the DR score went from 23.5 to 21.6. So that was a big win. And then the final question, how does this technology compare to something like ganglion cell complex analysis for detecting glaucoma in the earliest stages?
Well, it's structure function. It's this exact, it's the chicken or egg. Which one goes first? You're going to do both of them. Structure function, ganglion cell analysis on the OCT structure, photopic negative response on the ERG function. What goes first? Hard to say. Depends on the case. You're going to do both at the end of the day.
Yeah. And I, the one thing I would say is that, ERG gives us different information. Like, one beautiful thing that came out of Weinreb's group, when they looked at ERG in glaucoma, they did a baseline ERG and then they did a follow-up ERG after doing a TRAB. And the ERG scores improved tremendously over the course of 1 week. So like we're just scratching the surface on what the ERGs can give us in optic nerve disease like glaucoma. And so it gets really, really exciting when we're talking about a functional test that can change over the course of a week once you can alter the pressure that much. And so so it's really kind of exciting times when it comes to this technology. And finally, we have something available to us that is portable, convenient, patients like it, and has attractive reimbursement. So when you put all those things together, it makes me really excited, not only about today, but the near future.
And it's just, again, I reiterate how much patients have loved this, Mike, how much they've been impressed by this, because you can bring it right to them and EKG the back of the eye. And I think that's valuable. That is valuable to have patients excited about their care. When they are excited about their care, they are more bought into what you're saying, and that is going to benefit everybody. And that is an important point, I think.
Yeah, and I think as doctors, when it comes to diabetic retinopathy, care, and Nate, you and I have seen a lot of it. I can't remember, myself being this excited about diabetic retinopathy care in a long time. And
Yep.
so it really benefits patient outcomes, but generates excitement as a doctor.